Let's look at the liver architecture a little bit. So let's start with the classic hepatic lobule. So the core concept is that the shape and layout of the lobules of the liver are in shapes of hexagonal units. So basically, you have these hexagonal units that are basically lobules that make up the connective tissue of the liver. So if we zoom into one hexagon, so you can see that the central vein is located in the middle of all the hexagon units, which is the functional unit of the liver. And then in the center we have the central vein, and at the corners, we have the portal triads. So there's a portal triad at each corner, right? So the every portal triad contains these three structures. So can you see that this is a portal triad and this is a portal triad? So one portal triad contains one branch of the portal vein, this blue one, and then one branch of the hepatic artery, which is this portal arteriole, and then one bile ductule, which drains the bile out of the liver. So you have one bile ductule, one branch of the hepatic artery, which is the oxygen rich blood, and then one branch of the portal vein, which is the nutrient rich oxygen poor blood, right? So the oxygen poor blood comes here, which is nutrient rich. It gets all this toxins metabolized, and then the branch of the hepatic artery, the oxygen rich blood, is present here, right? So the oxygen poor blood gets drained into the inferior vena cava through the interlobular vein, and the branch of the hepatic artery, basically that's the oxygen rich blood, which is coming to the liver from the systemic circulation. So you have a portal triad, right, which has this portal venule. It has the hepatic arteriole or the portal arteriole, and then it also has the bile duct. And the central vein is right in the middle. So there's a blood flow versus a bile flow. This is very important. So the blood enters from the portal vein branch, right? So this portal vein branch brings the blood in. And also the blood also enters through the hepatic artery branch. So the blood also enters through the portal arteriole. And the blood flows through all these sinusoids. Through all these sinusoids, the blood flows into the central vein through the sinusoids and exits. All the blood exits via this central vein into the interlobular vein, and this goes into the hepatic vein, right? So the blood flows in the opposite direction. Bile is made by hepatocytes. The hepatocytes make the bile, and that flows into the bile canaliculi, and that all this bile basically drains towards the bile ductules in the portal triads. So here you have these bile ductules. So it's very important to note that the blood and bile flow in opposite direction. Now, what are sinusoids? Sinusoids are like capillary-like vascular channels that run between the plates of hepatocytes, and they carry mixed blood. The portal and arterial blood is mixed here, and the sinusoids have like this mixed blood, right? And the key features of the sinusoids are that it has fenestrated endothelium. So that fenestrated endothelium is a little bit leaky, right? Similar to the one we see in the kidney. I'll show it to you here. So these are the sinusoids of the liver, right? So the sinusoids of the liver have these leaky fenestrated endotheliums, and that allows easy exchange of nutrients, toxins, and proteins. This leakiness is essential for proper liver function. Now there's something called the space of Deci, and the space of Deci is basically the space between the sinusoidal endothelium and the hepatocyte surface. And this location between the sinusoidal epithelium and the hepatocyte surface is the function of this area, and the space of Deci actually is the site of exchange between blood and hepatocytes. So the plasma bathes hepatocytes microvilli, and okay, so we have which cells do we have here? This is the space of Deci, right? So the space of Deci was the sinusoidal endothelium, this location between the sinusoidal epithelium and the hepatocyte surface. And this is the site of exchange between blood and hepatocytes, and plasma bathes these hepatocyte microvilli. Here we also have stellate cells, right? So stellate cells are present here. They're basically in a quiescent state or a sleeping state, and they store vitamin A. But in an injury case, whenever some injury happens here, you get activated stellate cells, and that produces collagen, and that leads to fibrosis. So in cirrhosis, with time, fibrosis occurs of the liver connective tissue through the stellate cells, because the activated injured stellate cells produce collagen, and that leads to fibrosis. So basically, any chronic injury like alcohol, hepatitis, or NASH syndrome, it leads to stellate cell activation, and that leads to collagen deposition in the space of Deci. And that leads to sinusoidal narrowing and fibrosis, and that increases the portal resistance, and that leads to portal hypertension. So this directly explains why you get cirrhosis, and then varices and ascites and splenomegaly. Now we also have something called as the Kupffer cells. The Kupffer cells sit inside these sinusoids. So the Kupffer cells are literally part of the inside part of the sinusoids. The functions of the Kupffer cells include phagocytosing bacteria, endotoxins, and old red blood cells. So it's part of the reticuloendothelial system because they're phagocytosing the bacteria, endotoxins, and old red blood cells. So what happens in sepsis? In sepsis, Kupffer cells release cytokines, and these cytokines cause systemic inflammation. In portal hypertension, there's increased bacterial translocation from the gut, and that also leads to these Kupffer cells overactivating themselves. Now, hepatocytes are the workhorses, right? So the hepatocytes organization is into plates and cords that radiate towards the central vein. So let's look at a hepatocyte here. These plates and cords lead to the central vein in the middle, and you have a portal triad at every corner of the hexagonal structure. So these plates and cords, they have an apical surface that leads to the bile canaliculi, and they have a basolateral surface that leads to the sinusoids, right? So it's important to see that the apical surface of these hepatocytes face the bile canaliculi, and they basically leads to bile secretion. But the basolateral surface faces the sinusoids, and that exchanges with blood the nutrients, toxins, albumin, and all of that is secreted into the blood, right? So that is important. Remember that the sinusoids lead the bile flow leads to the bile areas, to the bile duct in the portal triad, but in the opposite direction the blood flows towards the central vein. So this is something you can see, here the blood is flowing towards the central vein, but the bile is flowing towards the bile ducts. So basically all this arrangement of sinusoids, which are like special capillary-like channels lined by the fenestrated epithelium, lets plasma interact with the hepatocytes more freely. And the space of Deci, which is like the perisinusoidal space between the sinusoidal endothelium and hepatocytes. So the space of Deci is like this perisinusoidal space between the sinusoidal epithelium and the hepatocytes, where the site of exchange between the plasma and hepatocytes is happening, and this is where the stellate cells were living. Then we have the Kupffer cells, which were basically resident macrophages sitting along the sinusoids, and they were phagocytosizing the bacteria, especially from the gut via the portal blood, clearing the old RBCs. Now we look at three zones of the hepatocytes, right? So the hepatic acinus has three zones, zone 1, 2, and 3. Now, there's an oxygen gradient across these three zones. And what happens is that since there's a dual blood supply, the portal vein brings 80% of the nutrient-rich, less oxygenated blood, which is coming from all the GIT areas, and the hepatic artery brings 20% oxygen-rich blood. So the oxygen gradient is highest near the portal triad, right? There's the highest oxygen gradient exists near the portal triad, and it's lowest near the central vein, because the central vein is taking all of this demetabolized mixed blood towards the inferior vena cava, right? So what happens is that the zone 1 is periportal. It's on the outside area. It's closest to the portal triad, and it's most oxygenated. So whenever some ischemia occurs, this survives ischemia best. And the zone 3 is is the centrilobular or the pericentral area, and it's closest to the central vein, and it's least oxygenated, so it gets injured first in ischemia, and the zone 2 is in between. So the zone 1 is first exposed to blood coming from the portal triad. So toxins arriving via blood may hit here early, often noted with viral hepatitis patterns in many teaching zemas. So you'll see that viral hepatitis is hitting these areas first, but this is more resistant to hypoxia because it has a it has the highest oxygen rich part compared to the other two zones. The third zone, which is near the central vein, is first injured in ischemia. It leads to shock, heart failure, and congestive hepatopathy here. So there's a very high CYP 450 activity here, which basically the CYP 450, if you remember your paracetamol, the acetaminophen was being converted using the CYP 450 mechanism, and this area converts many drugs into toxic metabolites, and common injuries happen here. The classic case is an acetaminophen toxicity, and then also alcohol related injury where the alcoholic hepatitis happens is often prominent in the zone 3. Also CCl4, carbon chloride 4, and other metabolic toxins appear to affect the zone 3 first. So zone 3 is like low oxygen, CYP 450, and dies first in shock and drug toxicity. Now there are some biliary structures, and the basic duct anatomy is important here. So you have the right and left hepatic ducts that are forming the common hepatic duct, right? Let me show that to you. So the right and left hepatic duct here joins to form the common hepatic duct. The gallbladder drains via the cystic duct, right? So the gallbladder itself drains via the cystic duct, but the liver drains by the right and left hepatic duct, which drain into the common hepatic duct. And then the common hepatic duct and the cystic duct drain via the common bile duct. So the common bile duct joins the main pancreatic duct and itself near the duodenum at the ampulla of the water, and this flow is controlled by the sphincter of Oddi. Okay, so into the main ampulla of water, this flow is controlled by the main sphincter of Oddi. And even though we have the main sphincter of Oddi that is controlling this common bile duct and pancreatic duct joining and it's opening into the ampulla of water, we have two further small sphincters. There's a bile duct sphincter also, and there's a pancreatic duct sphincter also. So we have two mini sphincters also, which are responsible for this common bile duct separately and the pancreatic duct separately. But then there's also sphincter of Oddi, which controls the secretions moving into the ampulla of water of the duodenum. So here you can see this ampulla of water inside the middle part of the duodenum, right? Now remember, whenever you have gallstones at the ampulla, if you have a gallstone here, you get a double duct sign. Basically the gallstones are at the confluence ampulla, so it can block both things. It can block the common bile duct also, and it can also block the pancreatic duct. This produces the classic imaging concept of double duct sign. So there's a dilatation of obstruction of both the common bile duct and the pancreatic duct, and this is seen with ampullary obstruction or head of pancreas cancer. This you can see is the double duct sign, where you can see obstruction of the pancreatic duct and the common bile duct. So whenever there's a problem with the ampulla of water, it blocks both the secretions of the common bile duct and the pancreatic duct, and you are able to see a double duct sign here, right? So cholangiography of the biliary structure shows filling defects in the gallbladder and common bile duct. Gallstones that reach the confluence, the joining of the common bile duct and pancreatic duct at the ampulla of water, can block both of the ducts, common bile and the pancreatic duct, which leads to double duct sign, causing both cholangitis and pancreatitis respectively. So tumors that arise in the head of the pancreas here, usually ductal adenocarcinoma, can cause obstruction of the common bile duct. This leads to an enlarged non-tender gallbladder with jaundice. This is the Courvoisier sign. So, a Courvoisier sign or Courvoisier terrier sign are seen in states that in a patient with painless jaundice and enlarged gallbladder or right upper quadrant mass, the cause is unlikely to be gallstones and therefore presumes the cause to be an obstructing pancreatic or biliary neoplasm until proven otherwise. Because a gallbladder containing stones is likely to have been chronically diseased and subject to be repeated, although possibly subclinical episodes of cholecystitis. This results in extensive fibrosis of the gallbladder wall, which is then unable to distend when obstructed. So, this is the Courvoisier sign. Right, there are some exceptions. You can pause this video and look at the exceptions yourself, but it is enough to know that the Courvoisier sign is this non-tender gallbladder, right? Enlarged non-tender gallbladder with jaundice. Um, we've covered the three zones. We've covered the dual supply. We've covered the apical surface, Kupffer cells, hepatic stellate cells. So yeah, that's about it. I'm going to stop the video here and then I'm going to start with the femoral region in the next video.